Hi, everyone. We'll start in a few minutes to give the opportunity for latecomers to join. So bear with me. We'll start in a few minutes. Hi, everyone. We'll give it one more minute and then I will make us start. Okay, everyone, I'll make a start now. First of all, thanks for joining the session. I'm very excited to be given the opportunity to present on our work and kind of my view on AI in healthcare today. So my name is Nicolas. I'm the principal architect at Orbis International. And today I'm going to talk about the role of AI in democratizing healthcare and AI and other technologies, but also a focus on artificial intelligence during this conversation. So everything I'm going to say today can be applied to other areas of healthcare as well, but I will mostly focus on eye care and ophthalmology just because this is the area I'm the most familiar with. So I'm going to start with a bit of context. Around the world, there are 380 million people that are either blind or visually impaired. And more importantly, 77% of those cases are avoidable, which means that without new treatments or new diagnosis techniques, those cases should not be happening. So this is really a logistics problem. We need to identify the patients and we need to provide them the treatment they need. We don't, for those particular cases, there's no need for new drugs or new diagnostic techniques. We just need to find the patients and treat them. So there are nine out of 10 people with vision loss actually live in low to middle income countries. So there's a very significant disparity in inequalities when it comes to eye health and healthcare in general. To give kind of a sense of scale, there are about 137 low to middle income countries. That is about 70% of the countries around the globe, which means that this is a global problem at a global scale, and it is not a regional one. And the reason why there's such disparities are mostly due to barriers to access healthcare. And barriers could be, for example, monetary. So the cost of transportation to medical facilities could be one. But something that is a common thread across everything we do and what organizations like ours do is that there is a significant shortage of specialists in those countries and regions. So for example, in a low to middle income countries, there will be up to 20 times fewer specialists in ophthalmology and eye care compared to high income economies of Western countries such as the United States or where I'm based in the United Kingdom. So we need to basically break down those barriers to provide people access to the healthcare they need. So how it is normally done. So traditionally, kind of the model is to do in-person care and training. So in our organization, Orbis, we have, for example, one way we're doing this is a plane. So you can see here in the background of that photograph, we have a plane that is equipped with a state-of-the-art surgical facility, as well as kind of training and teaching facilities. And that plane will land in a low to middle income country, and we'll do just that. We'll have in-person care for local patients, and also doing training of healthcare workers, so that in turn they can provide that same level of care to the local community. Other organizations may not have a plane, but mainly follow this kind of model of in-person care and training. The difficulty with this is that it is very difficult to scale. In our case, we cannot really have more planes. It's not realistic. We only land in 6 to 8 countries a year. This leaves about 130 other low to middle income countries that we need to impact that we are not present in through this operation. In addition, this is not resilient to global disruptions. The obvious one is COVID. From overnight, our plane was grounded, which prevented us from getting to those countries and communities. Similarly, the community of volunteers that work with us could not get to those countries either. So we needed to find ways around that to make sure we can still assist whoever need access to this healthcare in other ways. So kind of the obvious way one would do this is through digitalization of services. And this is exactly what we've done. So we have a platform called CyberSight. And this is a platform built at a global scale for global reach. So we want to be able to reach all ophthalmologists and eye care professionals in low to middle income countries. And the goal of the platform is pretty much to upskill local healthcare workers. So we want to offer telemedicine services and learning capabilities. And what I mean is telemedicine, we have a doctor-to-doctor telemedicine platform whereby local healthcare professionals can submit patient cases to the service, and they will be matched up with mentors from all around the world who have experts in ophthalmology and eye care. And together they will work on patient cases, and eventually they will provide better care for local patients, but also help local healthcare workers to gain the knowledge and expertise and experience they need to kind of provide similar level of care to the patient. So this is similar to what we do with a plane, with a training on the ground, but this is done almost fully remotely. And we also have learning capabilities. So we have one of the largest learning and training platform for eye care around the world. And really the main point here is that we provide free access to both those services. So everything we do in learning and training and everything we do in telemedicine is fully accessible to users in low to middle income countries. And again, this is to kind of lower these barriers of entry and make sure that as long as we have a device with an internet browser and in connectivity, we're able to make the most out of our services. So this is kind of an extreme example of what we can achieve using this technology. So this is a remote surgical mentorship. And what you see is on the left-hand side, this is a team on the ground operating on a patient. And on the right-hand side is a volunteer working with us at Orbis. And there is a microscope above the patient with a camera in it so that the expert, the remote expert, can see everything the actual surgeon can see. And by doing this, allows them to guide the surgeon, provide recommendation, answer any questions they may have to make sure that the surgery is as successful as possible, and that the team on the ground kind of, again, learn from the experience and will be able to use that knowledge in the future. So this is really kind of an example of how, even though we couldn't fly and reach those communities physically, we were still able to provide valuable kind of services to them. So I talked about telemedicine. I talked about kind of providing a learning platform for healthcare workers in those countries and communities. Kind of the next logical step is to think about artificial intelligence. There's a reason why the title of this slide is the AI evolution, and there is kind of this R and for revolution in bracket, is because when deep learning, this kind of new fancy machine learning technique became kind of a thing about 10 years ago now, myself and colleagues, we all thought that because it was so good at, for example, detecting disease on medical images, that by now we would have the systems deployed everywhere. Turned out it's not really the case. Obviously, we have some implementation of AI here and there when it comes to healthcare, but it's certainly not the scale that we were all expecting. Surprisingly, it's a lot more on the upstream of that. So when it comes to drug discovery and creating new drugs and therapeutics, this is where AI is really shining right now. When it comes to diagnostics, there's a lot of effort going into that, but not a lot of implementation just yet. As I say, it exists, but we don't see it day to day as a patient. One of the reasons for that, I will argue, is that the business case is really difficult to make. It's actually really difficult to sell, especially in Western countries or high-income countries where we have good healthcare systems that may be under pressure, but are usually well-resourced. So the AI is kind of a incremental step rather than a revolution in those systems. Whereas I will make the case that the areas where AI would be most beneficial are the areas where it's not implemented yet, which are in low to middle income countries, where there's a big shortage of specialists, as I mentioned before. So I want to make the case for AI in eye care, and that's also true for other areas of healthcare that relying on screening. And in order to do that, I'm using this funnel model. And this funnel is a representation of the journey for patients from screening or the first point of contact with a healthcare system through to treatment. And you can see that on the left-hand side, we have capacity here, and because we need to be able to see as many patients as possible. This is why this is a wider bit of the funnel, is because the population of patients you need to see is a subset of your entire country population or region population, or could even be the entire population if it's a national screening program, for example. And as you go through that funnel and that process, it narrows down just because the number of patients is smaller and smaller as you go through the process. And eventually, by the time you get to the end or towards the end of the process, which is usually treatment, you have a relatively small number of patients there. And at that point, you don't really need capacity, you need expertise. So you need to be able to make the right decision for treatment and for the patient. So the capacity problem is a huge problem because it basically everything that is going wrong stems from there, not having enough capacity. And if you don't have the capacity, you're going to have people that are never seen by the healthcare system, never assessed by the healthcare system, which means they will never go through that funnel, which means they will lead to more cases of avoidable blindness. This is what we want to avoid. So I believe that AI can help with both. There's certainly a lot of work on the expertise side, but I'm going to talk about how AI can help with the capacity, which is really what we want to tackle, because those are areas of very high pressure in the healthcare system in those communities. So we want to use AI, or more specifically assistive artificial intelligence, to increase capacity in those healthcare systems to help with that initial bit of the funnel model. So this is a photograph, a screening session. In the background, you have a healthcare professional. In the foreground, we have a patient being imaged by what we call a fundus camera. This is a retinal camera that will take a photo of the back of your eye. The whole concept of using AI in this process is to upskill the healthcare workers. And the reason for that is we want them to be confident enough to participate in this in the clinical workflow, so that they can participate and be part of this initial capacity that is needed at the start of the funnel model, so that the patient can be identified, and if they need to see a specialist or to go down the funnel, they can be redirected and flagged at that point. So just to give an example of what those images look like, on the left-hand side, this is a normal eye, a healthy eye. On the right-hand side, this is a diseased eye, and this is diabetic retinopathy, which is a complication from diabetes. And I want to make 2 points based on those images. The first one is that just acquiring those images is great to document, the patient and their eye health. It's not very helpful if no one is there to look at them and to interpret them and to assess and make a decision based on them. This is why capacity is needed at this point. The other point is that this is an obvious example where anyone with any kind of training in this will be able to tell that the right-hand side image is a diseased eye. In reality, things are much more subtle than that. Sometimes the features that you need to detect, the lesions you need to detect, are a few pixels wide, and you have huge time pressure. Usually screeners have 10 to 30 seconds to look at this very high resolution photograph. So it's very likely that something might be missed or the right decision might be made. So this is why we're saying that having additional assistive technologies that help with this will be very valuable. And this is the reason why we also built an AI platform that we use in our mission at Orbis. This is not only us doing it, it's certainly not. There's many commercial companies, we have academic groups, there's other kind of organizations developing similar platforms, but this is our take on it. So this is based on deep learning. As I said, deep learning is kind of a special way using machine learning that is showing really good results, especially when it comes to this application, which is machine vision, so using a machine to interpret images. And we are using, I'm not going to go into technical details here, but we're using frameworks such as PyTorch and FastAI. They're all open source tools. So this is one application where we're basically standing on the shoulders of giants when it comes to the tools we're using for those products. So what it will do is it takes an image as an input. This is a retinal image, as I explained before, and it will do 4 things. It will do referral recommendation. So this is, should the patient just been asked to come back in 6 months, 12 months, or the patient be asked to go see a specialist for further assessment and treatment. We do disease grading, which is to evaluate the progress of disease. That will be very important, because whether you are suffering for early disease or a further progress disease, it will dictate which kind of treatment and kind of next step we'll take. We do anomaly detection, which is detecting any deviation from a healthy eye. And lastly, and maybe more importantly, we do lesion visualization, which is all these overlays that you see on this photograph. We provide both qualitative and quantitative information to the user so that they can make the best possible decision for their patients, but also maybe learn from it as well to detect some more subtle cues in the image as they gain experience using the system. So this platform is called CyberSat AI. It can be used kind of in 2 contexts. It is integrated in our telemedicine platform that I talked about earlier. So it is kind of a human in the loop workflow. The main workflow is still between the local healthcare professional and an expert, a volunteer expert working together. But the AI will provide a report with a lot of details, as I showed earlier, and will provide additional context for that patient case, so that the healthcare workers and the mentors, the expert, can work together with that information provided by the AI. We can also use it as a standalone tool that can be integrated in existing screening workflows. So we are doing work with existing screening programs around the world, and our tool can just be integrated in those to be used. And maybe more importantly, this is also available free of charge. So similar to our telemedicine and our learning platform, all our AI tools are available free of charge to users in low to middle income countries. And the aim is, again, to make sure that the barriers of entry is as low as possible. So the big question is AI actually useful? We know that AI is good at matching or exceeding the performance of experts when it comes to looking at an image and, for example, detecting disease on that image. But the real question is, will it actually benefit the patients on the ground? And for a very long time, we actually didn't know. But now we're starting to see more and more of these studies coming in that provide pretty positive results and show there is actually a benefit to the patient. Just to quickly mention that we ran our own randomized clinical trial. This was in Rwanda in Africa. And we basically showed that if you provide patients with an instant artificial intelligence result, they will be more likely to show up at referrals than if you were to delay those results by a few days, which is what you normally have with a telemedicine workflow. You don't get the results right away, you get the results later and you get contacted back. So this shows that by using AI, we get more patients through that funnel, which means that there's more opportunity for these patients to be further assessed and treated. And this is a very important step to make sure that we decrease those number of avoidable blindness cases, which is our ultimate aim here. Again, this is one example out of many, but this is very promising. And there is a URL here and a QR code if you want to learn more about this study, but I'm happy to share more on this if there's any question. I think there is the things we've learned while we try to using AI in healthcare and kind of observing other organizations trying to do the same. Those are kind of the requirements we are following when it comes to our implementation of AI. So AI in healthcare should benefit everyone. This is kind of an obvious one, but it should focus on those with a greater needs. Again, I don't think AI is going to make a huge difference in high income economies or Western countries. I think will make, but I think will be very valuable in low to middle income countries. Collaboration is key, as it usually is with problems on that scale. We need to create data sets that are large and diverse, and we know that the availability of very large data sets spur research and innovation and ultimately lead to better product to serve patients on the ground. And this is, as I mentioned, the scale of this problem is global, so we need a global representation in everything we do, not just in the data sets to make sure that all communities are represented in those data sets and no one is kind of left behind, but also at all levels of implementation and even stakeholders in those implementation programs. So this is those are the kind of our three main requirements we're following there. And I want to finish with what I see as the kind of full stack of healthcare democratization using technology. And again, this is a very focused on what we're doing in eye care, but this will apply similarly to other areas of healthcare. So ultimately, what we want is training and upskilling. Again, this is what we also do in person, but this is the aim also of our kind of digital services. With the technology that we have to do that are numerous, but my message behind it is that no one technology will be sufficient on it by itself. It is a combination of those kind of this full stack that will probably and hopefully make a difference on the ground when it comes to avoidable blindness. So we have telemedicine and telehealth. We have assistive artificial intelligence. We have simulation training, and this is how do we train, for example, for surgery remotely. So we have fake eyes where surgeons can train on, or we have virtual reality simulations that kind of mimic what surgeons will normally do. And all of these are being explored as ways to provide training while not being necessarily able to be in person in those communities. We do live mentoring, as I showed with the surgery, but we also do live mentoring when it comes to patient cases. We do live demonstrations, and we do live teaching as well. And we have a massive learning library so that, again, anyone with a device can access that information and have everything they need to provide best of class care for the patients. Finally, the end product of this is capacity. Again, going back to that funnel kind of model, we want as much capacity as possible so we don't miss anyone and everyone will have the opportunity to be assessed and treated if needed. It will create expertise and it will create confidence. Again, we want the confidence of healthcare workers on the ground to take part into the clinical workflow so they can help with very high pressure situations on the ground. So I think this is it for me. See our website on this slide if you want to learn more about Orbis. It's orbis.org. If you want to learn more about our digital services, this is cyberside.org. My email address is nicolas.jaccard@orbis.org. I'm more than happy to have any conversation about what we do. And, we love sharing learnings and learn from others and collaborate. So again, if you want to get in touch, don't hesitate to do so. And I believe we may have a few minutes for Q&A. So if anyone has any question, I think we have 4 minutes before the next session. So if anyone any question, just maybe put it in the chat. And if not, I'm happy to continue the conversation offline. So just give it a few seconds or minutes to see if there's any questions, or you can raise your hand as well, I think. Maybe. So I don't think there's any question, which is fine. As I said, just don't hesitate to contact us offline, contact me offline. My email is there. Again, if you need anything or want to discuss anything that's been presented today, just don't hesitate to contact me. And yeah, that's it. I wish you a good afternoon, morning, evening, wherever you are, and I hope you enjoy the rest of the sessions. So thank you very much, and see you soon.